Myself, Dr. V. Srichan Reddy, MD, Radiology, in Department of Radio Diagnosis, working as a senior resident in the Department of Radio Diagnosis in D.Y. Patil Medical College, Kolhapur. Today, we are going to discuss about imaging of approach of ring enhancing lesions in the brain. So, I want to simplify the topic. So, from ages, it was a difficult to differentiate few of the lesions one from the other and which overlap sometimes. So I want to simplify it for you. So coming to ring enhancing lesions, this is the mnemonic for the widely used around the world. M for the metastasis, magic DR. It's a magical DR. So M for metastasis, A for abscess, G for glioblastoma and granuloma, I for infarct, that I mean subacute infarct, C for contusions, and A for AIDS in toxoplasmosis, lymphoma in the AIDS, and D for demyelination, and R for resolving hematoma and radiation necrosis. So in ring enhancing lesion, the center part and the wall. So peripheral enhancing wall and center. The center of peripheral enhancing lesion will be mostly contents. What are the contents you can see? The ones necrotic tissue, dead tissue, hemorrhage, fluid, pus in case of abscess, and normal tissue in case of demyelination, repositive and progressive end, you will have a normal tissue. So coming to the pattern of enhancement of the ring. So it depends upon the pattern of enhancement of the ring. We'll differentiate the lesions. It will helpful for the differential diagnosis. And if it is the if come to the benign abscess, it will be smooth, and you are able to see a smooth ring. And it is the and if it is a lesion, it's a neoplasm. You will have a thick, irregular, nodular kind of a enhancement and of the wall, and if you are able to see, it is a cyst with mural nodule, mostly seen in the posterior in the children, pilocytic astrocytoma, all those kind. And this is the incomplete ring enhancement, which is commonly seen in demyelination, like MS tumefactive demyelination. And always you remember the always you remember the open ring. This opening of the ring is towards the cortex. Okay. So next important sequence helpful to cleanse the diagnosis in the ring enhancing lesions is the diffusion. So depends upon the restriction of the diffusion, where the diffusion got restricted. You can differentiate the lesions. Like if the diffusion restriction is in the center, then it is called we'll keep it in abscess. And if it is in the peripheral wall diffusion, peripheral irregular diffusion, you can in GBM and neoplasms. And this is very important. Like diffusion restriction excrescences of the inner wall. What do you mean by excrescences? Is like a projections. In fungal, there will be fungal hyphae. So the wall from the wall, the hyphae will be projects. These hyphae are avascular and they don't show enhancement, but they will show diffusion restriction. So this is how you will differentiate between the pyogenic from fungal abscess. So you will have a diffusion restriction excrescences of inner wall. Okay. And coming to diffusion restriction in the like a concentric target, you will see in the toxoplasmosis, and innermost rings will show sometimes diffusion restriction. So, and again, the in demyelination, the normal progressive and the not at open end, there will be a diffusion restriction you can see, and homogeneous diffusion restriction is seen in the lymphoma. So this helpful in the diagnosis. So this is a case you are able to see there's a irregular peripheral diffusion restriction, and this is the glioblastoma multiformis. And you can see the progressive end and the normal brain tissue you can able to see, and progressive end. And this is the demyelination. And this is the case you are able to see there is a central diffusion restriction and excessive vasogenic edema. You are able to excessive vasogenic edema is there. Yes, you are able to see excessive vasogenic edema and central diffusion restriction, which we can keep it in abscess. This is the case of an abscess. So there is we can cleanse the diagnosis in the perilesional edema also. In so what say if there is infective so all infective will doesn't show extensive edema, and all neoplasms will doesn't show extensive edema. So this may helpful. So most of the abscesses and mets in like GBM which doesn't show very extensive edema, but mets will show extensive edema. So abscess and metastasis will show extensive edema, and the we can see demyelination, and NCC is like a, so few of the NCCs will show edema, not so much, and less edema. And what are few of them will be conglomeration, like small ring clubbing at one side. So what are the conditions you can able to see? Tuberculosis, NCCs as the most commonly seen, and the blastomycosis and nocardiosis is less common. But mostly you can see tuberculosis, conglomeration lesions. Okay, and this is a case you are able to see in the right cerebral hemisphere. You will see multiple ring and irregular ring enhancing lesions which are conglomerated and shows surrounding edema and effacement of fourth ventricle with obstructive hydrocephalus, and this is the case of a tuberculosis. And coming to this case, this is a case we are I want to discuss. Yeah, this is the case I want to discuss. You are able to see multiple lesions in it's a child. You are able to see multiple lesions which in the occipital region you are able to see, and the frontal and parietal, and this lesion which is seen in frontal region. These lesions and shows extensive edema and mass effect, midline shift, effacement of the ipsilateral lateral ventricle, and coming to diffusion, you are able to central diffusion restriction and contrast peripheral smooth. You are able to see there is a very smooth enhancement. So what is the diagnosis? Mostly it is an abscess. So it is a classical abscess. So how the abscess will form in the brain? So usually the for the complete formation of abscess it takes 14 days, and it is in 4 stages. Stage 1 is like first if the infection starts, it is called early cerebritis, and focal infective area will start, and it doesn't have any wall, just edema. And next the late cerebritis, the pus cells will come and incorporate in that, and thin fibrous capsule is formed between 4 to 9. It is the late cerebritis. And next coming to capsule formation, and this capsule formation which is on cortical side is better seen on than the ventricle side. And this at this stage when you give a contrast, when you will see an enhancement of the wall. And late cerebritis where you there is a thick wall is seen, and here the edema starts subsiding and gliosis starting. Gliosis means death of the brain tissue, and due to the symptoms will start due to the edema and mass effects. Then the internal of the abscess and the fever. And this is what I am speaking from the start, the fungal hyphae, which doesn't show enhancement in these internal projections, intracavitary projections, which show diffusion restriction, and which doesn't show enhancement. So this is the fungal abscess. So which you won't see in pyogenic abscess. These intracavitary projections. So this is the differences you can see from the fungal, pyogenic, and parasitic. So post contrast T1, there is a thick, thin wall and ring enhancement is seen. Fungal abscess, you will say irregular defined ring enhancement, and so everything will have a shown as a ring enhanced. These are called ring enhancing lesions. So what is that? It is the you can see fungal projections. So intracavitary fungal projections which doesn't show enhancement. Well, and in the parasitic, the toxoplasmosis is all the parasitic, which is eccentric target sign. What is this eccentric target sign? Is means which I will be discussing in the next slide. But it is a thrombosed vein, which we'll see in the periphery of the cyst. So and coming to and in T2 you will see a concentric target sign, and the T2 the projections is like a hypo to iso-intense signal, and these are concentric rings in the sometimes very rarely you can say concentric rings, and diffusion, the central diffusion restrictions, and these both will show variable diffusion restrictions. So Coming to another case is a case. This is a case of a 15. I remember it is a 15 or 20 years male patient. You will see multiple ring enhancing lesions, which are very small in size, and less than 2 centimeters, and which are you can see distributed in bilateral cerebral hemispheres in the basal ganglion and all, and you are not able to see any diffusion restriction on diffusion. And what is here the important is T2. If you come to T2, the enhancement is there, and T2 is there. The T2 central of T2 is hypo. The hypo T2, this is very important. Why I'm saying this? The central T2 hypo, central solid caseating tuberculoma. So only T2 hypointense center will be in solid caseating. The rest will be hyper. So that is why I'm saying it is important. So there are three stages in the tuberculoma: non-caseating, solid caseating tuberculoma with liquefaction. Where in caseating tuberculoma with liquefaction, you will see diffusion restriction. So solid caseating tuberculoma, there is no diffusion restriction, but both solid caseating tuberculoma and caseating tuberculoma will show peripheral enhancement, but hypointense T2 is in solid caseating tuberculoma. This is how you differentiate the from one from the other. And this is another case. So sometimes they'll be in NCC and tuberculoma. It's a big question mark. Sometimes it is very close, and we couldn't able to differentiate which is tuberculoma, which is NCC, and both will be very small in size. Both will be multiple, and both shows enhancement. Both shows edema. So how? So this is the case. So then the interesting is the MRS. So if you the last stage is the MRS. The MRS will differentiate between the it's a tuberculoma or a NCC. So this is the case you are able to see central and diffusion restriction is there, peripheral enhancement is there, and you are able to is a thick wall, and you are able to see is a lactate peak in this. So lactate peak, lipid peak is there. Lipid peak is there. So this is a tuberculosis. So lipid peak is usual in MRS. Will see lipid peak in tuberculosis, and this is one case. It should be like similar. So you will multiple ring enhancing lesions, but here you are able in few of them shows a small nodules in the lung that can be a scolex. We can and coming to this case, you are able to see multiple lesions with peripheral enhancement. Yeah, multiple lesions with peripheral enhancement, peripheral ring enhancement, and you are able to see double lactate peak inversion invert double like in intermediate TE. When you give intermediate TE on MRS, you will able to see it inverted double lactate peak, which is mostly like to be and which is an amino acid peaks, and which is most commonly, and you can able to see it is in the NCC. So neurocystic sarcosis. So these are the kinds you are able to differentiate and helpful to clinical diagnosis. So you have a four stages in the neurocystic sarcosis: vascular, colloid, granular, and calcified. So how you differentiate? How I remember is simple. So in colloid stage, you will have a scolex. So if you have we have first, if you should search for scolex. Any dot calcification, any dot is there in the ring, like when you should wear a ring, right? Ring with dot. So any dot is there, then the 50 more than 50 to 90% of your diagnosis is there. It's a NCC, not tuberculosis. If you not so, but most of the time it is not. There will be different stages will be there, and the multiple lesions will be in different stages, so it is difficult. So you have to search for scolex, any colloid stage is there or not. Then in vascular stage, it should be like a normal T2 T1 will be iso intense, and it looks like a Swiss cheese, like cheese will be multiple holes, like 6 feet, and single will be like a hole in a dot. Like so, colloid vascular, both T1 T2 will be hyper, and surrounding edema is there, and the edema increases in the granular stage. So same will be in colloid, but in granular stage the edema will be more. So in calcified, there will be no edema. the edema will be reduced, and it will be, in few cases you are able to see the edema, and calcifications is in this stage. So you have to search for the colics and the rest of the things. These how you differentiate between NCC and tuberculosis. Usually the literature says the NCC is less than 20 mm, tuberculoma is more than 20 mm, and NCC or single or multiple can be seen, but conglomerate is less likely, and few of the cases are reported, and you can see the conglomeration. And the tuberculoma is single, multiple, and multiple conglomerations are seen, and more edema is seen in tuberculosis, and more irregular margins will be seen in the, so margins also you're able to see irregular margins are seen. And what I told you, this is the important, the scolex part, which is most common in the NCC neural nodule, what I mean. And the amino acid and lactate peak is in NCC, and lipid peak, there is a very high lipid peak we will see in tuberculosis in the MRS. So coming to the toxoplasmosis. So toxoplasmosis, it's like in the associated with the AIDS in the pregnant women and what, and there will be two signs which will differentiate it from the others. One is eccentric target sign, one is concentric target sign. So you should know which sign where to see. That is important. The eccentric target sign is seen only on post contrast T1 weighted images. Okay, and the eccentric target is, why eccentric target is seen, as you can see there is a thrombosed vein in the eccentric. So it is thrombosed, and you will see a eccentric like a target sign. That is the important. And you'll see intermediate hypodense areas which are compact, which usually due to necrosis, and the peripherally enhancing part is due to inflammation. So eccentric target is due to the thrombosed vein, and concentric target you are able to see concentric target, that hypo and hyper alternately, and the inner rings will show diffusion restriction in few of the cases, and this is seen only on T2 images. So concentric target sign is seen on T2 weighted images, eccentric target sign is seen on T1 weighted images. So that is important. And here, so histopathologically, we can see the hemorrhage, fibrin rich, necrosis, compact, and edema is seen in toxoplasmosis. And coming to this is the important slide. So most of the time when the abscess is, you are able to see large abscess, and the abscess will be very irregular, or it's a GBM. You doesn't know the lesion it looks like an abscess also, it looks like a GBM also. Then how you differentiate? So usually on post contrast, if it is it's a lesion is a fairly big size, so you have to, so all the, from the lecture I'm started from the, you have to see the wall smooth, it's an irregular, and nodularity of the wall, nodularity, and diffusion. So central diffusion restriction or peripheral wall diffusion restriction, and the metastasis shows edema, extensive edema, and all these kinds will differentiate one from the other. So this slide will be helpful to you to differentiate when it was difficult to benign versus malignant, abscess versus neoplasm. Okay, the cost, the wall enhancement, neoplasm, the wall enhancement is nodular, and abscess will be the smooth, and surrounding edema variable, but the abscess will show extensive edema compared to the neoplasm. And rim size, I think I'm saying about, we are, so I'm talking, you are able to understand, I'm talking about the thickness of the wall. It should be more than 5, usually says in the, more towards the neoplasm, less than 5. And the enhancement pre-contrast, it will be like iso to hyper intense in the abscess intermediate signal, and iso to hypo intense due to free radicals in T2 weighted images and intermediate signal, and stellate lesions. So small stellate lesions, most common in the abscess, then towards the infective, then neoplasm. So daughter light lesions, stellate lesions are most common in abscess. Perfusion, so the perfusion is also another imaging modality which is helpful to, and in neoplasms there will be high grade neoplasms, there will be increased CBR, so high perfusion, right? And in abscess the perfusion will be low compared to normal. white matter. So and diffusion restriction, as I told, there's a low ADC and high, so low diffusion restriction ion ADC, low diffusion ion, but it should not, but can overlap the tumors in toxoplasmosis sarcosis. Sometimes it can overlap, and MRS, the in neoplasms, lactate peak, choline peak will be high. Choline lactate peak will be very high, and abscess, the elevated lactate, and so elevated lactate and amino acids like leucine, isoleucine, valine, without succinate peak, you can, mostly it's an abscess. If succinate peak is there, and you have to repeat the acetate, and diffusion restriction is intermediate to low, consider as a, I have read in the article, there is as a cystic and in the cystic usually amino acid peak and lactate peak. Thank you.